I'm Barbara Herman. I am president of the LCU Nursing Alumni Association, and I am deeply honored today to present to you our speaker, Dalton Keel. Dalton is currently enrolled in a DNP program, praying that he will finish in December, and asks and covets your prayers for that, although I suspect, knowing Dalton, that he is doing quite well. His presentation today is implementing text reminders. Dalton currently is nursing adjunct faculty here at LCU. He's been doing that for a year and 10 months. He works at the 301st MDS Functional Training Manager at the U.S. Air Force Reserve. He's a nurse consultant at the Texas Department of State Health Services in the Administrative Agency of StarCare. Prior to that, he was Assistant Director of Nurses at Sears Methodist Retirement System. Has been a captain flight nurse in the United States Air Force. Prior to that was a house supervisor at Grace, and before that he was at the Heart Hospital. And prior to that, he has pages. On a wonderful personal note, Dalton is married to Olivia. Between the two of them, they have 5 children, ranging in age from 21 until 9. And they have 2 grandchildren, a 3-year-old and 4-year-old. And that's an awesome place to be in life, too.
Yeah.
So, Dalton, before you speak, Jamie Romey is going to tell us a few things. I have 2 more just brief announcements as Jamie's coming up. We have an Alumni Association planning meeting immediately after this. If you, obviously you are alumni, and we'd love to have you involved in our organization. We do, aside from fellowshipping, plan events for during the year, help with fundraising. We have our annual alumni event February 5th at the Caldwell Center. It'll be at 6:30 in the evening. We do encourage you to make reservations. Business attire that evening. We're going to have music, hors d'oeuvres. We have Bart Rager as our motivational speaker that night. Just come and join our family. You're an important part of our story, and let us be part of yours. All right, Jamie.
Oh, thank you. Thank you, Barbara. I am excited. I'm the co-chair of the research on the IOMU Sigma Theta Tau International Board here in Lubbock. It's the Honor Society for Nursing, and so Joanne has mentored me along, and she asked me to have the pleasure and the privilege of telling you some exciting news about some of the LCU students that she nominated for Rising Star of Excellence for LCU. And so Erin Whitley's in the back. She got accepted for Puerto Rico.
Yeah.
And we're presenting using news to detect sepsis and poster presentation. Not here is Stephanie Dunkel. She'll be presenting some work on Muse in Puerto Rico as well. Crystal Pelham is doing some research on our Mom Baby unit at Covenant, looking at the Kudos Reward Program and its impact on nursing retention. And she also got accepted into Puerto Rico's International Research Congress, as well as she will be presenting at the Biennial in Las Vegas with a couple of the other students. 2 of the other students, Kim Fivish, will be presenting in Las Vegas at the Biennial, and so will Amanda Raimundo, who's right here. So, congratulations. And so I didn't want to take up too much of Dalton's time. I started working with Dalton in 1995, for y'all that don't know.
I was afraid she was going to bring pictures or something.
Yeah,
It's just,
I had to tell us stories from way back then.
I had no idea what was going to happen.
And not as educated back then, but
No.
I can't wait to hear you talk.
Okay, well, thanks for the introduction. Thanks for all those words about our program and where we're going and who's going with us and all that stuff. I am faculty here. I take great pride in teaching research here to undergrads, and I am blue. I graduated BSN and MSN here, and had to truck off to UT Houston to figure out what I was going to do in life, and so DNP, I guess, is the way to go. So CCRNK, if anybody's wondering, that's a brand new thing that just came out. Because I'm not directly at the bedside, but I'm directly involved with the training of nurses that do participate at the bedside now with a functional training manager position that I have at the 301st Fighter Wing. I have a knowledge-based CCRN now, so I just did that actually yesterday. I just renewed it, so and I'm no longer at the bedside. So and E is now available for those of you who work in virtual ICUs and tele-step down and all that stuff. Lots of great things on the horizon. Okay, so Today I'm going to talk to you a little bit about implementing text reminders in social media, hashtag step in the right direction. And where this all came about was I have a really fantastic physician who works with us in El Paso, and he was more than willing to hop on board and try to do something in social media, texting, that type of thing. And there are a lot of barriers, probably a lot of barriers to anything that you come to really want to do or make work in life. But you got to figure out a way to get around them, jump over them, do whatever you need to do. So we did, and this all worked out. So I'll give you a brief introduction. We'll walk through this, why technology is important, background information about this, the methods, design, all the scientific data things, and conclusions. This is kind of a splice between a really technical presentation and sort of one that was presented to actually lay persons at a conference. So there's some combination slides in here, and feel free to ask questions throughout. Well, I'll probably try to work through this, and then we'll get the questions at the end here. So talk about our results, the conclusions we came to, considerations for next time if somebody else wants to do this or who wants to take it up. And then the Texas Spectrum of Engagement, that's kind of what I'm involved in right now with the Department of State Health Services Administrative Agency, and the Lewin Change Model, which is what we use for this particular project. So, healthcare for HIV patients is key treatment, is a key treatment component. And what that really means is you've got to take your medicine, you've got to go to the doctor. You got to follow up with your social worker and care providers. And those things have to be available and readily utilized, or those people find themselves in a bad way. So missed appointments were a problem, adherence was a problem. Patients living with HIV and AIDS require strong commitment to treatment regimens, and it takes a little doing to get people on board sometimes. Some psychological changes have to be in place. And then the consistent attendance of medical appointments, so it prolongs and enhances the quality of life, and these missed appointments were a frequent problem for this particular physician. So that's where this all came about. So we got to talking one day, just kind of sitting over coffee, saying that this spectrum of engagement and this spectrum overall, this is a little cut off here, but what this does is it tells you that in our society, there's 82% of these diagnoses go linked to care, about 66%. And I've shown this several times in other presentations that I've presented. It's called the spectrum of engagement. And so here you have 37% retaining care. You have 33% that are prescribed ART, which is antiretroviral therapy. And then about 25% of this 82 initial are the ones that are actually viral suppressed. Now, ideally, we'd want that to be the other way around. You'd want this to be really high and this to be really low. So how do we get there? That's another problem that we're dealing with as well. Well, it's engaging folks. And what we started looking at putting this health system together, this little health awareness function, is age is more than a number, and where do we begin? Who are the people that we want to target? What population? What are we dealing with? So we figured out that a primary range for the patients that are seen there fall into this category. And here you can see that the diagnosis of HIV infection in the United States, this is back in 2009, and you can see here that the 15 to the 34 age range is usually the highest peak here, and then 25, 29, I'm sorry, that's 24, yeah, this is broken up a little different. So, and with regards to youth, HIV disproportionately affects young black men who have sex with men and young gay and bisexual men of all races and ethnicities. So we started talking about how can we get these folks on board with showing up to their appointments. How could we use social media or media of any adjunct to do this? And what we found is that internet adoption has just skyrocketed through this. From 1995 up to 2012, I mean, it's just like soared. And then here you can see all adults 18 plus and then 65 and over has really trended up since 2000 up till now and continues to trend up. So anybody familiar with these things as you're growing up? Some of us are different ages and stages in life. So yeah, this was back when I started out with the internet. It was bing, 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 you know, that kind of, these, my internet gurus in here, they probably laugh about that stuff. So yeah, this was a big deal. So we started trying to figure out how people interact with each other and what they're looking for on the internet. How do we reach them? What do we do here? So what we did was we looked at what are the top social media sites. How do they play into this? And what are people looking at in these social media sites? So then, have any of y'all heard of these? You've heard of some of these over here? I'd never heard of any of them. Yeah. So I checked out a few of them, and some of them are pretty interesting. This one's one of them. So Google Plus, that's probably starting to get into the realm of what we know, what we deal with. MySpace, not really in the U.S. much anymore, but over in Europe, they tend to use it more. Pinterest, LinkedIn. Anybody? What's the next one? Facebook. Ah, you're close. Yeah. All right. So now we're looking at this as of 2013. That's when this is starting to go on. Okay. All right. Now it's changed a little. Now you've got Pinterest, you've got Tumblr, Instagram, all these other ones that are coming up. And one of them that's actually not in here is Tinder, the site where you take, kind of swipe left or right if you want to say that guy's hot or this girl's hot or whatever, and then you want to meet them. They show you where they're at in the vicinity of you and stuff like that. Yeah, social media, man, it's a great thing. So. It's important to know this because we're trying to find a platform that we can communicate with this patient population, and so that's really the issue here is like how do we reach these people? How do we figure out a way to remind these folks to come to these appointments? So then we started looking at how do people use smartphones? Okay, so of course here this age group, of course, man, you can find my 9-year-old, 10-year-old, 12-year-old all in the Facebook or not in Facebook, but in their iPad, usually walking around head down. So then this is the youth coming up right here, right? And then this is me, some of y'all, most of us. But here, this is interesting, right? 65 and over, they're retired and getting on Facebook. Or I had a funny one the other day. A lady said, "My face. I'm getting on my face today." Okay. Sounds great. All right, so then we started looking at cell phone activities, and all this stuff comes from Pew. It's widely available. How many people use their phone to take a picture, text, access internet, email? You can see it steadily climbs. Record a video, download an app, health information, bank account. So cell phone activity by percent, and what this does is 81%, it shows 81% of these users send or receive a text, right? So we thought, okay, fantastic. Text is probably the way to go. And any of you guys use or get a text reminder when you go to the doc now? Yeah, probably everybody, yeah.
Multiple.
Yeah, sure. Yeah, I even get a phone call too, and they say you didn't reply one or no or whatever. So 60% access the internet, send and receive emails. So then now we're dealing with El Paso. Okay, so let's get on board here and think about. All right, well now some of the population that we're seeing over there, they're poor. They don't have money. This is a population that struggles to pay for medication or things of that nature. So let alone transportation or anything of that nature. Okay, so what we do is we go down through here, find kind of what this sticks out to us, and these things show up, and we're like, all right, well, we've got some relevant data. We're finding some things out, and so really the Black, non-Hispanic, and Hispanic is really the population that's the greatest impact in that region, and so we wanted to get an idea of who's got broadband or smartphone at home, right? And so we saw that these are the numbers that are actually shooting out at us. They're the ones that are like on the highest trend. And this is white non-Hispanic. It's actually kind of staying relatively the same. And then, you know, the age group, it's shooting up. Okay, so we're thinking, well, so if mom or whoever has this, or uncle or somebody, then I bet there's some kid in the household that's got a cell phone or something that they can receive a text or whatever on. It's just a matter of getting adequate consent and dealing with a little thing called House Bill 300. So, let me go back there. So this is where it all starts out. Collected our data, we were finding out our background, and our hypothesis is, you know, these text message reminders will significantly decrease the number of missed appointments to physician, lab, case management. And we wanted to find a web-based text messaging reminder that we could implement at Texas State Department of Internal Medicine Care Clinic in El Paso. So this was to remind the patients about medical follow-up appointments, lab work reminders, and appointments with social workers. So we wanted to just kind of dedicate it to those three areas because those are really important and those really tend to deal with adherence the most. So went out, looked for meta-analysis, kind of did our own, did some systematic literature review for evidence, found these two really good articles for text messaging in the clinics that really laid the groundwork and could show how to get sort of a skeletal structure in place. So Google and Gmail platform and the Google Plus system is what we opted to go in with, okay? The biggest thing is there's no fee because a lot of these networks that people are using attached to EMRs and things of that nature, there's a huge expense with them. I mean, if it's not already in place, then you've got a huge expense or some sort of significant cost that's going to really take away from your budget. Okay, so having no fee was a great thing for us. We were like, yes, we're in. All right, so telephone disclosure and consent was attained. As the clients were coming in, what we started doing was telling them about this. Okay, and so I have to give sort of a shout out here. Diego Magallanes is a guy that set this up as a student assistant that works with our program in El Paso. This kid is fantastic. He put all of this stuff together. He set up the number. He got everything in. And this kid is in the 20 range, right? So it was fantastic. He got us all set up. He knew exactly how to do this. It was no problem for him. We were like, yes, fantastic. Okay, so we started talking about telephone disclosure and consent. When they would come in to see our case manager, he would sit with an iPad and show them how to use it and show them how to read it, show them how to consent to electronic data consent, okay? And really what that amounts to is they had to alter their consent for medical record disclosure in just a way that said electronic or e-consent, telephone consent, that sort of thing. So that what we could do was every time they came in, we asked, did your number change or anything of that nature? So that we weren't sending a blind text or sending a text to a number that wasn't relevant to the client, okay? And it was encrypted capable, so that was a big deal because we could encrypt the text message, and if they didn't have the right passcode, they couldn't see the message. But of course, also, this is just a reminder for text data. But we're also testing the limits of this capability as well, okay? So design, we did a convenience sample with existing data analysis and pre-text reminder. What we did was we set this up in the care clinic there, and our participants were just screened as opt-in or out if they wanted to participate or if they didn't. The pretext was patients keeping scheduled appointments, not receiving a message reminder from September 1, 2013 through November 30, 2013. And then post-text was measured number of patients keeping a scheduled appointment who did receive a text message from January 1, 2014 to March 31, 2014. So integrating this, our text data contained the current clinical contact information that we had on file for when they consented. And then we utilized that to telephonically contact them and text them initially, okay? And then what we figured out is we could actually link link a video for educational opportunities or to sort of orient them to the clinic if this was a first-timer that they could watch at their convenience, or they could get in, look at it, know what was going to happen, kind of what they expect, and who these faces were that they were going to see. Okay, and that kind of put a lot of people at ease when we followed up later. So subject matter and delivery of the message was adjusted for health literacy level, because that's a huge thing right now. And I don't know if you can Google health literacy and you'll get 1 million hits. And excuse me, class LEP is a big thing, CLAS-LEP. And those things are specific to cultural and linguistically appropriate use of data or whatever you have in your office, like any of your pamphlets or any of your stuff that has medical information on it. It needs to be culturally and linguistically appropriate, okay, and to an education level. So you guys can find out more about that by Googling it. Then privacy concerns were addressed because what we were getting a lot of hits from was tech legal. Those folks were coming in and saying, hey man, you know, I'm not sure this is all kosher. I'm not sure this all works. So we need to probably look at it again. And finally we got them to look through it, say yes, okay, we'll do it. Like I said, with the changes in the telephonic consent and the label as to how it read for e-data or telephonic communication. So it was really just a matter of adjusting one line in their consent form. I thought I had a picture of this about right there, but it doesn't seem to be coming up. So required resources, we needed a strong community backing and operational support from the care clinic and the folks at the compliance office for sure, and tech legal. They were great. Adequate staff that was trained on the initial startup and how this was going to be implemented. And then the use of smartphones, you know, some people were okay with them, some people had a little technical difficulty getting into it. Then training on the office iPads, that was probably the biggest thing. But with Diego, he was able to sit with the folks and actually do this throughout the day, or, you know, in Spanish, yeah, or in English, or whatever they needed. And we actually had some smartphones that were being donated. I don't know if you know this or not, but like your phone will dial 911 without you even having it activated. And so a lot of people, when you get rid of the phone, they just donate it, or they throw it away, or they do whatever. It sits in a drawer at home, right? So if you donate these things, they can actually be activated and used for this purpose, because it's only linked to this number, this Google number, okay? So we used some of those for folks who just had no resource to get a phone. So this is what our pretext group looked like, okay? We'll get into the nuts and bolts now. So there was 148 total folks during this time frame here, and 116 patients showed, 32 patients did not show, okay? Then when we started sending texts January 1 through March 31st of 2014, we had 125 patients, 101 who showed, and 24 who did not show. So I already identified our barriers there. So another way of looking at this was our reschedules, which we didn't even consider at that time, was really just focused on these two things. You can see the way this is lined out is October to December 13, and then January to March. So just looking at it a different way in this data. And looking at here the show rate, no show rate, and how that tallies out statistically. And then extended text clinical behavior. And I'm sorry I keep turning my back to y'all. But, and then again, you know, the same time frame. And then what we started to notice was our initial hypothesis and what we thought was going to happen didn't happen. What happened was, it wasn't necessarily the patients were going to show up because we text reminded them, but what they were doing was rescheduling. Yeah, so we witnessed this phenomenon out of nowhere that we weren't even, you know, looking for or anything, weren't even ready to record or have anything to do with, but that's why it starts showing up there, is because the no-show rate actually went down, the reschedule rate went up, and then you actually did have people coming to their appointment because they came at a more convenient time for them. But during the course of getting their appointment set up, they may have thought, in this culture, it's a whole different world out there. Okay, so in this culture, they thought, they're being very nice to me, they're doing all these things for me, I'll take this appointment, right? But then they have the option to reschedule when they get this text message, and they're doing it at a time that's more convenient for them. Okay? So, and that was just the same deal with the post-text data with the analysis. So our conclusions were the text message reminders didn't significantly increase the clinic attendance like we thought. It did increase the number of reschedules, and we needed a longer evaluation period to really determine the effectiveness of this. So that's what we're doing right now. We're currently in that. And patients, we really wanted them to feel empowered by this and self-sufficient, connected to their resources. And then we wanted them to be able to contact the clinic or social worker for health needs related to their HIV when it was appropriate for them, when it was convenient for them. And it works really well because when they receive the text message, they go in and just look at what all's there, and they can even create an avatar, go into this program, and have a chat, which I think they're still doing on Fridays from what I remember, and have a chat around their clinical issues or their social issues or whatever. And other people that look like them, and feel like them, and act like them are available to talk and bounce that stuff off of. And there's no patient information. I mean, it's an avatar with, made up names and things like that. So, then medication appointment compliance is really where we're trying to go with this. And so that leads us into the Texas spectrum of engagement. Texas created this engagement spectrum, and it has 6 domains. It's increasing HIV awareness among numbers of general public, community leaders, policymakers, to increase the access to HIV and efforts for high-risk groups. And then the full diagnosis of everyone infected with HIV, the timely linkage to HIV-related care and treatment, the continuous participation of systems in care and treatment, and increased viral suppression. Because as long as your viral suppression is high in your community, your chances of catching HIV are much higher, okay? With it lower, the risk is lower, the chance is lower, okay? And that's what we're trying to get to. So we had to figure this sort of model out here to figure out how we're going to do that. Part of it is public awareness. That's what I do every January, is come out and talk about HIV, and I do that a lot during the year elsewhere. Find full diagnosis on these clients that are out there in the community. And that the western region is what I cover, so that's Amarillo, Midland, Odessa, Lubbock, all the way out to El Paso, everything in between there. So that's a huge region. And that's not including the other 4 parts of Texas that are, 5 parts of Texas that are regioned out with this. But getting them the full diagnosis, then full participation in care is the biggest element there. And that's where we get the linkage and the engagement piece. And then targeted prevention, successful linkage, and then you end up with viral suppression. So the goals that we had set for this were missed appointments are obviously a sign of poor adherence, or can be, depending on what the problems are, the reasons around it. In a medical home setting, missed medical appointments mean the opportunity to connect with your social worker is missed. So that gives, maybe your bills are behind, maybe your transportation is askew this month or something. Maybe you missed the bus. Any number of things, but that missing this portion right here is a crucial link for the engagement problem. And then improving health and quality of life for these individuals, because if you take your medicine and you're going to your appointments and you're engaged in this care, you'll see that their quality of life goes up, their extension of life goes up. So in statistical data, you'll see the folks who adhere to their regimen live a long, happy life, and genetics is what gets them, not HIV. Okay? So improving the efficiencies, and this really works with throughput or workflow study, because people are missing their appointments. Then you have empty slots, productivity, and this goes more to the business side of this, is down. You've got like an open slot. You could get somebody in maybe, or maybe somebody can't get there on time, but it kind of really affects your day-to-day, and that affects the bottom line in a business sense. So reducing no-show appointments, and then increasing interaction with the case manager. So then, I think my battery's dying on here, so I'm having some difficulties here. But anyways, our desired outcomes again was reduce no-show rate by 50%, which it was currently at 21% during that time. So we got it down to around that number. And we wanted to implement this in a small group change setting so that we could see what kind of impact it would have on the larger community. So the platform of choice, again, we talked about Google Plus. It was for the access, the ease of use, the cost effectiveness, is appropriate for the low healthcare literacy, and could lead to utilization of additional mediums for communication. The Lewin model that I talked about, this adapts from Lewin change model, and basically what it talks around is unfreezing the concept or the way of thinking, and then in those phases is the initiation where you bring it to the table and say, this is what we're doing, this is how we're going to do it, and then you go through the change where there's adoption and adaptation, and then you have a refreezing where this becomes the norm. And then now what we're doing is this is cyclical as well, so we're back at this point and we're adapting it to the next phase, how we're going to implement it or use it in other clinics or other arenas. So true measurement and evaluation of this would be a reduction in no-show rate by 10% initially is what we thought, but we got way more than that, so we were very happy with that. Other items to be measured were health outcomes, viral load undetectable, CD4 count, reduction in hospitalization, adherence to ART therapy, the timeliness of the labs. You know, they leave their office, go right and get the labs, and they have them available for the next time. Patient satisfaction, are they happy with it? They hate it? They don't want to use it? And so far, it's worked great. Everyone has been happy with it. It's been phenomenal. You know, this affects, again, you know, clinic revenues if you're more in private practice, but what this would be talking about is this is a grant service, so what happens is you get a specific amount of dollars, and if you don't use those dollars, they get taken away. So if you're not billing for your revenues or you're not billing for labs or things of that nature, then that money is going to get pulled away at the end of the year. So that's how it works. And then limiting overtime of staff. So, you know, it really, one of the things that it reduces is like in the way that it used to work is you get an appointment card in the mail, right? You get a little postcard or something. So, or you get a little card at the appointment. You lose that. You know, stick it in my pocket, wash it, something like that. So the stamps reduces the cost of the stamps, reduces the paper, reduces the time that's put into it by a staff or staffers in doing this. And so after you get all the technical stuff out of the way, you talk about why the importance of social media. So right now is the time. I mean, if you're not in it, if you're not involved with it, I mean, now's the time, because social media is just an explosion. 1 in 5 people on the internet, they're looking for somebody who shares the same health condition. And they want to be part of communities that look like them or sound like them or act like them. 1 in 4 look for somebody like me, who's got MS, who's got HIV, who's got, you know, something. And the evolution of this comes from in the networking for men who have sex with men, and the social networking evolution. Typically, it used to be that you would go out in the physical environment, like the bars, the clubs, the parks, where these guys were meeting, and you would tell them, you know, be aware, you know, prevention and all this, you know, condoms, all those kinds of things. And then it moved along to 2.0, where you have MSM or race-specific chat rooms, and the hugest disparity in the MSM population, the men who have sex with men, is African American and Hispanic. So again, they started having chat rooms and race-specific websites. Okay, now we're in 3.0, where you have young black men, MSMs, on Facebook, Twitter, with blogs, all kinds of other types of social media, and mobile MSMs or race-specific applications with GPS abilities. If you check out some of the AIDS.gov has a ton of applications that are available for specifically what I deal with, but they have they've had great results. They've even had people go on blast for, you know, they're like, hey man, you missed your appointment, you weren't there today, or whatever, you know, or something like that, you know, and just because it's in a controlled environment where not everyone's seeing this or it's not publicly available, but they're messaging or talking, and you know, it's been pretty interesting to see these go into effect. So who in your organization is best suited to assist with social media? Well, definitely these guys back here, the technical wizards, yeah. But in our organization, it was me, because we had this idea, we wanted to take it forward, and nobody else was willing to get involved, so I did, and it worked out. So our conclusions, this comes from the Mayo Clinic Center for Social Media. And social media starts with the people who will be using it, and that's just a matter of fact. I mean, you're either in or you're out. Resources for texting capabilities are abundant, little to no cost for implementation, and it reduces the cost of paper postage waste for reminder cards, and allows for unimaginable processes before the technology that were just not even available. So in summary, change is a constant dynamic. You know, get on board or the ship's sailing. And take a peek into the HIT, the Health Information Technology, and how it can affect HIV care or supplement whatever you do or wherever you're at. Okay? And then stimulate interest on ways to use health information technology to improve patient care and maybe drive research. I mean, this was totally a fluke. Never thought this was ever going to be a big deal, but it turned out, I mean, it's a really big deal, and it's worked great for us. Some references we use, and Mayo Clinic for Social Media, that's a book called Social Media Revolution, #Revolution, Bringing the Social Media #Revolution to Healthcare. And Mayo Clinic has that book's great. It gives you a lot of foundations for how to just jump in and get going. So that's about it. I'll take a few questions. I wanted to kind of get through this so I could get Dr. Alozzi to call in. I'm not sure if I'm about right on time with where he's going to call in. So any questions right now while we can? Yes?
I had a question for you, Dalton. I wrote it down in between the myths there, so it may be a little bit scattered, but I just wondered from a research or from a project standpoint on the front end, how did you all differentiate, and maybe it's in a previous history, how did you differentiate the question of if we have an increase in missed clinical visits or the result is increased no-shows, how did you differentiate that was not driven by patient satisfaction based off operating hours for the young population? Were there any clinical alterations in service delivery that would have enhanced clinical outcomes for the patients based off that?
That's a really good question. I'll just tell you how this clinic operates. It has 2 days that are specifically dedicated to this population, and they go from 8 to 12 on those 2 days. And then there's actually talk of extending to have an evening clinic now because of issues like that. It's there's so many logistical things involved in coordinating an appointment, not just in El Paso, but anywhere really, where transportation is an issue. And we don't have the best public transportation system here necessarily, and recently the taxis went away, there's Uber and that kind of thing now, but in El Paso it's particularly kind of a logistical issue because you have so many people spread out, about almost 800,000 people just all around the mountain, and then there's 1.7 million on the other side of the border. So I hope I hit all your points here and tell me if I don't, but we are looking to, and we would like to have an expansion to suit perhaps the capacity to get people at different times. What we would have to do is bring on probably another provider that could kind of offset that because of course we're dealing with one guy right now, and he's very busy. Anyway, he's the chief informatics officer at Texas Tech, so it's health information, busy all the time. So and he sees patients in the hospital, so definitely busy. So yeah, hope I hit all your points. If not, hit me back here and we'll talk. But that's really been the biggest concern for us. It's really been something that we continue to deal with both bus passes, tokens for taxis, and different things like that.
I just wondered, one other inquiry about what you found with regards to utilization and accessing the media and such in the population that you target is the 15 to 24. That age group operates on a different circadian rhythm than this my group.
Yeah, no doubt.
Like that 8 to 12 thing for them, they're still in sleep zone.
Yeah.
So I just wondered if there was utilization, if you could measure the frequency and the use of the social media, of what time of day are people making these visits to these sources? That might give you some indication.
Yeah, and I don't know if you guys know, but like on your iPhone and your Fitbit and all that stuff that's available now, you can basically plug in and tell when you're sleeping, when you're awake, and stuff like that. So that information can be downloaded and utilized in health information technology as well, so that if a person comes into the hospital, well, this person doesn't need a bath in the morning because they take their bath at night, or vice versa. And of course, that's a whole debate in another realm there, day and night bathing. But yeah, totally. The population, if you're taking care of these folks in the hospital or something, you see they're asleep during the day usually if there's nobody poking and prodding them. The kids over at the children's hospital and things like that. So yeah, there's a lot of adaptation, and of course, this was just a leap of faith kind of thing. So we tried with what we could and what we had, and tried to remedy as we could as we went. And that's what this is. I mean, it's a learning curve. It's a learning experience. I never thought that I'd be involved in it. I never thought I would get into anything like this. So, answer your question? Yeah, we really, we welcome input. We welcome other aspects. For sure, an evening clinic would be fantastic. Another provider in El Paso has an evening clinic 1 day a week. But there's not a whole lot of HIV providers out there. Yeah, and so we're working to kind of deal with that as well, and putting out an RFP. Hey, Dr. Lozzi.
Dalton, how are you, sir?
I'm doing well. You're on speakerphone and you're hooked up to the PA here. So.
Oh, fabulous. Good afternoon, everybody.
Good afternoon.
Can you hear everyone?
Yeah, I can hear you well.
Okay. All right, so I just got finished talking about the project and how it went in El Paso, and the good and the bad and the ugly. So whatever you have to say, shoot.
If you already talked about it, you can probably be a lot more eloquent than I can, Dalton. But the only thing I will say is that I think it's a really interesting process that different clinics should at least take a look at. When I give conversations like this to other HIV and wildlife providers across the country, even just primary care practices, I kind of push to them that you do want to try to leverage the technology that your clients are already using out there, be it tablets or cell phones or as simple as email, to try to get them involved as much as possible. We're actually doing a reanalysis of the data. We'll probably get it published in the next 3 to 4 months in either Internal Medicine Journal or the American Journal of Family Practice, since we presented it at their conference in December. So we're really excited about it, and I think it's something that a lot of people can use to sort of get their patients, what I like to call, activated in their care.
Fantastic. Yeah, that's kind of what we were just hitting on, and a couple of different questions from the audience about times with the clinics and circadian rhythms of the younger population and stuff like that.
Yeah.
I said you're only one man, so we're doing what we can with what we have right now, and try to.
I think the other thing, though, and you probably touched on this already, Dalton, is with younger clients, it's not even a question of their rhythm or lack of rhythm, it's their lack of wanting to respond to a phone call in the first place, right? So you almost have to think of it as, okay, if you have a resource that's dedicated to getting in touch with clients that aren't using a cell phone or don't have a home phone, but they do have a Cricket or a Glow phone that they'll use and religiously text on it because they get unlimited text. You sort of have to start to shift the way you think about communicating with that population, especially if we think of the burden of HIV in the country and where it's really shifting to.
Yeah, fantastic. Any questions you guys have I can field to him? Yes.
So I know that you targeted HIV, but are you already thinking about this as a potential model when we think about the burden of other chronic illnesses and how we know that simple support from providers makes a difference in blood sugar, blood pressure, et cetera, and do you see this as a model that might be lifted and adapted to other chronic illnesses?
Yeah, were you able to hear that?
No, I didn't hear the question.
Okay, it was centered around whether or not we could adapt this to other practices, to be inclusive of other types of practices and chronic illnesses. And I know that he does speak in different forums to different providers. He did mention about private practice and some family practice, people like that. He also sees people who are co-infected with HIV and hepatitis C in a clinic as well, and that's something. But I'll let him speak to it as well.
Yeah, I mean, I would say that in my mind, it can be used across the spectrum, right? Once you have a population who has access to any technology, then definitely you want to leverage that access, because as you know, whether you look at older people, middle-aged, or younger people, everybody's attached to some sort of device at least an hour to 2 hours a day. And so you may as well leverage that to keep them activated. I think that, I mean, for us, at least when I was at Texas Tech, and now that I enter a different phase in my career, I'm looking specifically for hepatitis C. Because it's a 12-week treatment condition, right? I can get them activated and engaged on an almost weekly basis, or even if we had to figure out a way to do it every 72 hours. So we would send text messages out to people every 72 to 96 hours just to remind them, hope you're doing okay, call us if there are any questions, because you really don't want to blow $95,000 on a 12-week hepatitis C treatment and have somebody not take it. And so I think that's one thing to definitely think about. But I think it goes across the spectrum. There's a lot of data out there already on using text messaging and email reminders and hypertension and diabetes, and just having pill reminders for patients. And so I think it's pretty validated. It was just in this situation, we had never done it locally before.
Yeah. Anybody else? Any questions? Okay, any parting thoughts, Dr. Losey?
No, I mean, good luck to all those that are going down this road. I think it's exciting. We did get a lot of benefit from it, but yeah, I think it's something to definitely look into.
Fantastic. All right. Well, with that, I'll let you go, and sure appreciate you calling in for me.
Anytime. Y'all have a fabulous rest of your day.
All right.
All right. Thank you. Bye-bye.
Okay. Anybody else? Any questions? Tried to stay within our time limit. No, this is kind of a lot of information to throw out at you guys. You're more than welcome to contact me. Dr. Long has my contact information. I usually carry some cards with me, but ran out of the office today, and they're in my other pants. So, yeah, I thank you guys. Appreciate you coming out on this wintry day. And
You know what we need is our virtual card on our phone, so we can just put it up and I'll get my
Totally,
email
yeah.
address, we're good to go.
I just got a new phone, so I don't have my card. And I actually did have my card loaded on another phone. So yeah, and I have a little app that you can bump it to somebody. So you just kind of touch your phones and bump it. Yeah, great era to be involved in social media. Get on board. It's going places. All right, thank you guys. Appreciate it.